we will start with the session today. Today I'm going to talk about principles of brachytherapy. The basic principles of brachytherapy have not changed much during the years of evolution of brachytherapy. Recent advances has made brachytherapy more efficient for the patient and more safe for the staff from radiation protection point of view. Brachy means short. In brachytherapy, we use discrete sources in close proximity to the tumor, and the best and most important advantage of brachytherapy is the rapid dose fall-off. Sir, I would like to, Dr. Deshpande, sir.
Yes, Dr. Marry.
Yes,
Kindly
your voice is
admit
coming.
the participants, sir. Actually, that is actually hanging my system.
No, your voice is coming, ma'am. Continue.
Yes.
You are audible, Dr. Marry.
Yes. And talking about the ideal choice of radionuclides, we will require radionuclides with photon energies in the range of low to medium range and with moderate gamma ray constant, and long half-life is preferred with high specific activity, and gaseous disintegration or daughter products are not desirable at all, and the nuclei should not disperse if source is damaged, and beta energy preferred will be low or no beta energy and low or no self-attenuation, and the radionuclide in its physical form shall be insoluble and non-toxic, and the radionuclide shall be easily available and cost-effective. Coming to the historical overview, radioactivity was described by Becquerel in 1988. Immediately after, in 1901, Danlos and Bloch performed first radium implant, and first schools of brachytherapy were at Stockholm, Memorial Sloan Kettering, and the Holt Radium Institute in Paris. And radium sources used extensively in the early years for the purpose of brachytherapy applications. The term brachytherapy, proposed first time by Forsell in 1931, and from 1940 to 1970s, cobalt-60, cesium-137, iridium-192 were first used for brachytherapy applications. In 1953, afterloading technique was first introduced by Henschke in New York, and this removed the hazard of radiation exposure. Also, iridium was also used first time by Henschke. And LDR brachytherapy became the gold standard for treatment. And if the brachytherapy applications can be classified into different schemes, and depending on the positioning of the radionuclide, dose rate of irradiation, duration of irradiation, and based on the loading pattern. Based on the positioning of radionuclide, it can be classified into intracavitary, interstitial, intraluminal, intravascular, and surface mold techniques. And dose rate of irradiation, it can be LDR, MDR, HDR, or PDR. And duration of irradiation, there can be permanent implants, and the implants can be temporary. And loading pattern, the preloading techniques were used in the initial years, and now we loading techniques. Surgical approach or positioning. The source positioning with respect in the applicators, and the applicators can be placed interstitially in intracavitary and intraluminal or endovascular. And if the source is in contact, but the contact is superficial, then it is called surface mold brachytherapy. And duration of irradiation, temporary and permanent. In temporary brachytherapy 192 and permanent radionuclides used for brachytherapy, permanent implants are iodine 125 or gold 198. And based on the dose rate, LDR, which is low dose rate, it is, if the dose rate is varying from 0.4 to 2 gray per hour, then it is called LDR application. Source used is cesium-137, the most commonly used one. And the medium dose rate or MDR is when the dose rate is between 2 to 12 gray per hour. And if the dose rate is more than 12 gray per hour, it is HDR. And ultra low dose rate is when the dose rate is between 0.01 to 0.3 gray per hour. And we can say roughly the doses will be in the LDR scheme, it is 10 gray per day, and MDR, it is 10 gray per hour. And in HDR, it can be 10 gray per minute. And source loading technique, we had preloading system where live sources were used and good clinical results, and the affordability, long-term results with lesser comorbidities were the advantages of the brachytherapy preloading system. And the disadvantages were radiation hazards, since the source and the applicator is a live radioactive source, the radiation hazard is higher and special instruments are required. And since it is a live source, the application becomes difficult and the person needs to be hasty in doing the application, and geometry does not maintained, and there is no scope, not or much scope for optimization. And afterloading technique avoids the radiation protection issue related with preloading, and this enables better applicator placement, because we don't need to be hasty in doing the application concerned about the radiation safety, and verification prior to source placement is possible, and minimum radiation hazard and all the advantages, the affordability, the clinical outcomes of the preloading technique is available with afterloading technique also. And remote controlled afterloading techniques, there is no radiation hazard since the source loading is also done remotely, and accurate placement is possible. The geometry could be maintained, and better dose distribution, and highly precise and short treatment time. And these afterloading techniques procedures could be done in daycare and mostly used in the HDR. And surface mold techniques. Surface molds are used for treatment of superficial tumors. Contour of the lesion is simulated using tissue equivalent material, and the mold is placed over the skin surface. The source can be in the form of tube, needles, or seeds. Source and skin depends upon the depth below the surface to be irradiated. So the distances of 0.5. Alternate mode is electron beam therapy. And the examples for surface mold applications where it can be done are for ear, lip, floor of mouth, penis, etc. And materials used for mold compounds, perspex or bexoid, or self-adhesive elastoplast, plaster of Paris, wax, etc. And the variation in the mold should not vary more than plus or minus 10%. The mold types can be planar, linear, or cylinder. And planar, when the plane or treatment area's curvature is less than that of hemisphere or semi-cylinder. Arrangements in molds, circular, square, or rectangle, and selection of treatment distance denoted by H, the distance between source plane and treatment surface, depends on the depth dose required and also dose to other tissues surrounding the implant. So Parker system allows you plane or volume of interest, and distribution rules are more elaborate and complex. For plain circular mold, area to be treated will be circular in shape. Source distribution depends on diameter of the circle D and the distance between the planes H. Single circle, and if D by H is 3, the distribution rule, if the D by H value is less than 3, the whole activity is distributed around the outer circle. And if D by H value is between 3 to 6, then 95% of the activity is distributed in the outer circle and 5% is placed in the center of the application. And if D by H value is activity is placed along the outer circle and 17% is placed along the inner circle and 3% is placed in the center. And the inner circle is half the diameter of outer circle. And if the area to be treated is square or rectangle, it is approximated to a square, and source distribution on 4 sides and inside, parallel to longer side, and separation between any 2 lines of sources shall be less than or equal to 2h, and separation between active ends any 2 sources in the same line shall be less than or equal to h. The linear activity of added line inside the area should be half of the peripheral activity, if in case a single line is added to encompass the whole tumor which needs to be treated, and 2 by 3 for more than 1 added line. And we need to apply elongation correction, depends upon the ratio of the 2 sides of the implant. The dosage values given in tables are strictly applicable for circles and squares. So for rectangular areas, the milligram hours read from the table should be increased by a factor to correct for the elongation. So if the ratio of the side is 1.5:1, then an elongation correction factor of 1.025 is applied to the milligram hour value taken from the table. If the ratio is 2:1, then the correction factor is 1.05. And if the ratio is 3.1, the correction factor is 1.09. And for a ratio of 4:1, the correction factor is 1.12. And for cylindrical mold are used in cases of neck, finger, penis, etc. And source distribution can be along a single ring or over the surface of a cylinder. Uniform dose over cylindrical surfaces, coaxial with and of smaller diameter than the source bearing cylinder. Source arrangement can be a series of coaxial rings or a series of equidistant lines parallel to the axis of cylinder. So in the scenario 1 of series of coaxial rings, a series of coaxial ring placed at separation less than the total activity is divided equally, 1:1 ratio. And if there are 3 rings, the center ring has half the activity of the end rings. So the ratio will be 1:1. or 2:1. And if more than 3 rings, each inner ring has 2/3 the activity of the end rings. So it will be 1:2, 3:2, 3:1. And in the scenario where series of equidistant lines parallel to the axis of cylinder is placed, then a series of straight lines of the required length parallel to the cylinder axis are arranged around the circumference of the cylinder at intervals 2 times the thickness of the applicator. Add a ring or short belt at right angles to the proposed ring at each end. So here are some pictures depicting the arrangements. In a plane or circular application, if the treatment volume is higher and 2 rings are added, then the radioactive source, 80% of the total activity is distributed along the outer circle, and the inner circle is of half the diameter of the outer circle, and 17% of the total activity is distributed along that circle, and 3% of the activity is placed in the center. And for a square pattern, again, the distance between the 2 lines and the ratio of the activity placed. In the inner line, if 1 line is added in the middle, then the activity along that line will be 1/3. And similarly, like the active length of the source is the dark line. So if the distance between the active length is not more than h, and it should not be more than h, and then the inner added line will have half the activity in the outer line. And if there are multiple lines added, then each inner line can have 2/3 of the activity. And if it is in the shape of a curve, so the radium to be for the mold, this is the mold, and this is the surface which needs to be treated, and the mold is placed over that, and this is the mold area along which the radioactive source is placed. And the reverse case, where the dark area is the concave surface which needs to be treated, and the mold is placed inside. So, and the mold surface is the inner surface along which the radioactive source is placed. And this is a picture of the cylindrical application. There can be single ring where the radioactive sources are placed equidistant from each other across a circle. And if it is a cylindrical shaped one, as we have discussed, there can be multiple coaxial rings. We can see here there are 4 rings, and here the sources are placed parallel to each other, and the distance between the 2 parallel lines is not more than 2 times the and both ends there are circular rings. And coming to the interstitial brachytherapy, sealed radioactive sources are directly implanted into the tumor in a geometric fashion, and first suggested by Alexander Graham Bell. The advantages are higher local doses in shorter time, rapid dose fall-off, better tumor control, lesser radiation morbidities, superior cosmetics, and functional preservation of organs treated. Disadvantages are radiation hazard in older days because of the preloaded sources, cost, and not applicable to inaccessible areas. And intention of the treatment is always radical. As radical brachytherapy, the treatment can be performed as radical brachytherapy alone for smaller lesions, or local boost in combination with EBRT for larger lesions, and this is never used for palliative purposes. And sources are directly implanted into the tissues in and around the malignant growth. For less accessible sites, permanent implants with short-lived radionuclides are used. Advantage is very high dose to the tumor lesion, while giving very low dose to the surrounding normal tissues. Drawback is absolute dose homogeneity is not possible because of the intensely high zone of the higher radiation immediately surrounding the implanted needle and the seed source. And examples of treatment sites are oral cavity, breast, etc. And this can be classified into planar implant or a volume implant. Planar implant is when tumor spread is under the skin surface or when lesion can be sandwiched between the parallel planes of implant. And for volume implant, it is used when lesion is to be treated is more than 2.5 centimeter in thickness. Plain implant leads to low dose region midway between the planes. If the distance is higher, if we go for planar implant, midway between the planes, the dose there can be low dose regions. And volume implant can be in the shape of sphere, cube, or cylinder. Techniques used when tumor spread is under the skin or lesion can be sandwiched between parallel planes of implant. For single plane implant, a single plane implant can effectively irradiate tissues of 1 centimeter thickness. So 0.5 centimeter on either side of the needle or the radioactive source. And the reference dose plane is 0.5 centimeter from the source plane. The dose is the minimum dose throughout the 1 centimeter thick slab. And the high ports immediately surrounding each source are assumed to be tolerated by tissues and its presence is ignored. So the distribution laws for different areas based on the volume to be treated. If the area is less than 25, the fractional activity in the periphery and the area shall be 2.2 by 3 by 1 by 3 and 1 by 3. And if the total area is between 25 to 100, the fractional activity in the periphery shall be half and in the area also can be half. And more than 100, then it can be 1 by 3, 2 by 3 distribution. And rules for the applications, the needles are placed not more than 1 centimeter from each other. For uncrossed ends, effective area has to be reduced by 10% for each uncrossed ends. So here in the figure, you can see each uncrossed ends, the effective area needs to be reduced by 10%. So here the total effective area is the encompassed area here, and here 10% reduction is there, and here it will be 20% reduction. And for multiplanar implant, planes should be parallel to each other. And two-plane implant, it is when the distance need to be treated, the thickness of the lesion to be treated is 1.5 to or 2.5 centimeter. Separation is more than 1 centimeter between the planes. Then we have to apply the corrections for the plane separation, and the multiplication factors used for the correction is the plane separation is 1.5 centimeters. Then a multiplication factor of 1.25 is used for the correction. And if the plane separation is 2 centimeters, then multiplication factor of 1.4. And for a separation of 2.5 centimeters, a correction factor of 1.5 is used. And volume implants are done when the lesion is more than 2.5 centimeter in thickness. Two-plane implant leads to low-dose regions midway between the shape of the sphere, cube, or cylinder. And table the radium, milligram radium values is valid when the length, breadth, and height are equal. So we need to apply the elongation correction factors when length, breadth, and height are not equal to the table values. Volume is divided into two parts, rind and core. For a sphere, rind is the surface or sphere, and for the cube, rind is the 6 faces, and for 2 ends. The total amount of radium activity, the shell will have 6 parts. And for a cylinder, the belt will have 4 parts, core will have part. And for cuboid, each side 1 part and core 2 parts. The elongation correction factor for different lengths 1.6% and 10%, and is belt should not be different parameters like linear strength, source distribution, spacing of the line source, and crossing needles for Manchester, Quimby, Paris, and computer systems. So the linear strength is variable for Manchester system, while it is constant for the rest of the systems. And source distribution is again for a planar implant, it is in the periphery, and it is uniform in the Manchester system, and it is uniformly distributed across for the other systems. And for areas, there are different areas which we have already seen for if it is a higher area application or it is a volume application. While the other sources, other systems, it is uniform and the line sources are placed in parallel planes. And for the computer system, the line sources in parallel or cylindrical volumes are applicable. And spacing of the line source can be constant, approximately 1 centimeter apart from each other or from crossing ends in Manchester and Quimby system. And it is constant, it can be constant or selective for the Paris as well as computer systems. And crossing needles are required to enhance the dose at the implant ends as per the Manchester guidelines as well as the Quimby guidelines. And in Paris system, the crossing needles are not used and active length is 30 to 40% longer, since in order to encompass the whole volume needs to be treated. The ends are not just using the needles, we have to increase the length by 30 to 40%. And same in the case of computer system. And the classical system components are distribution rules, dose specification and implant optimization criteria, and dose calculation aids. The distribution rules are given for a target volume. Distribution rules determine how to distribute radioactive sources and applicators in and around the target volume. And dose prescription and implant optimization criteria. Each system has a definition of prescribed dose. The above criteria determine dose homogeneity, normal tissue sparing, number of catheters implanted, and margins around target. And dose calculation aids. The older systems used tables that give dose delivered per milligram radium equivalent hour as a function of treatment volume or area. Recent Paris system uses computerized treatment planning to relate absorbed dose to source strength and treatment time. Features of Manchester system in terms of dose and dose rate, 6,000 to 8,000 are in 6 to 8 days. So 1,000 R per day at a dose rate of around 40 R per hour. And unit or use of radium is milligram radium hour, defined as amount of radium to give specified dose in 1 hour. And dose specification criteria, the effective minimum dose of 10% above absolute minimum dose. And linear activity is variable. The linear activity can be 0.66 radium equivalents per centimeter or 0.33 milligram radium equivalent per centimeter. And Quimby system is developed by edit Quimby, and dose is 5,000 to 6,000 R in 3 to 4 days. Uniform linear activity sources are distributed uniformly over the area or volume to be treated. We know that when the uniform activity sources are distributed uniformly, there can be inhomogeneity in the dose distribution. The areas near the source will have a higher dose. And this will lead to non-uniform dose distribution higher in the central region. And equal linear intensity, that is milligram radium equivalent per centimeter needles distributed uniformly in each implant, although spacing selected in 1 to 2 centimeter range according to implant size. Quimby tables, also known as nomograms, give the milligram radium equivalent hour to deliver stated exposure of 1000 R as function of the treatment volume or area. So 5,000 to 6,000 R over 3 to 4 days at a dose rate of 60 to 70 R per hour. No clear description of rules for distributing radium needles are available in the Quimby system. Crossing of the ends are recommended. Peripheral needles placed on or beyond the treatment volume boundaries. And dose specification criteria is inconsistent. And coming to the Paris system, radioactive sources in rectilinear or parallel arrangement so that centers are located in the same plane, which is perpendicular to the direction of sources. And the central plane is equidistant distribution. Linear activity is also uniform and identical. And source geometries can be linear single plane implants or squares or equilateral triangles, two plane implants. When we are going for a two plane implant, with respect to each source, each needle, we can find the squares or equilateral triangles for to do the source geometries and calculations accordingly. The basal dose rate and reference dose rate for the Paris system. Basal dose rate is defined as the arithmetic mean of the local minimum doses midway through an array of equally spaced ribbons for single plane implants. And for double plane implants, the basal dose rate is the dose rate in the central cross-sectional plane at the intersection of the perpendicular bisectors projected from the side of the triangle for triangular arrangement and at the geometric center for the square arrangements. When we are keeping two planes, then the source in the first plane and the sources in the second planes, we can arrange it in either triangular mode or in the square arrangement. The center point will be considered for the basal dose calculation. And the reference dose rate is equal to 85% of basal dose rate and the dose rate used for the dose prescription. So we can calculate the basal dose from the arithmetic mean of the local minimum doses if it is a single plane implant, or the arithmetic mean of the doses at the center point of the triangle or square arrangement, and then 85% of that is the reference dose prescription. Dose and dose rate for Paris system is 6,000 to 7,000 centigrade in 3 to 11 days. And the dose prescription point is the average of the minimum doses in the region defined by the source. And reference dose is 85% of the basal dose, and dose gradient is 15% between the reference dose and the basal dose. And source placement is reference isodose volume covers the treated volume sufficiently for the treatment purpose. And coming to temporary implants, radioactive sources removed after desirable dose has been delivered, then we call it a temporary implant. Rigid stainless steel needles or flexible Teflon, nylon guides or plastic tubes can be used. This can be preloaded or afterloaded. And permanent implants, Also, there are preloaded and afterloaded. Preloaded are rigid needles like of radium-226 or cesium-137. Afterloading can be either manual or remote. The advantages are flexibility of implant design, reduction of radiation exposure levels resulting in more accurate placement of needles and guides, and possible for less accessible sites, and continuous ultra low dose rate can be achieved for maximum biological effectiveness and better tissue heal, better effect in slow and radio resistant tumors, and improved mobility. Disadvantages are environmental hazard issues, dosimetric uncertainties for the later part of the treatment, as treatment becomes less effective, and source displacement is possible over the period of time. And for large tumors, it is difficult to implant and to maintain the geometry or achieve the geometry, and radiobiologically less effective for rapidly proliferating tumors. And computer-based systems, the implant systems are evolved through use of computers, and this made the life much easier in terms of dosimetry as well as the treatment planning. And implantation rules, sources of uniform strength and spaced uniformly of 1 to 1.5 centimeter different, and larger spacing for larger implants to cover the entire treatment volume. Active length 30 to 40% longer than the target length as ends are uncrossed, and treatment volume has sufficient safety margins, peripheral sources implanted on outer surface, and dose specified by isodose surface that surrounds the target, and whole planning is done with the help of computers. Possible to pre-plan the implants and complete isodose distribution corresponding to the final source distribution. This is rapid, fast, and helps modify the implant. And isodose patterns can be magnified and superimposed on implant radiograph. And localization of sources can be done using the orthogonal imaging method, stereo shift method, or by the 3D CT imaging. And dose calculation is based on the number of milligrams or millicurie in implant, location of each source with respect to dose calculation point, type of isotope used, and filtration of the encapsulation. And dose computation formalisms is the dose, the APM-TG43 algorithm use the Sievert integral directly for pre-calculated dose tables for radium and other long-lived sources. Dose rates in form of isodose curves are available, and for iridium and relatively short-lived implants, computer calculates the cumulative dose with decay correction. For intracavitary therapy, radioactive sources are placed in an existing cavity, usually inside a predefined applicator with special geometry. It's used in cases of cervix, endometrium, vagina, maxilla, nasopharynx, and treatments of such areas. And the Paris technique uses small quantity of radium, longer period of treatment, about 6 to 8 days. Total amount of radium for application is 8,000 milligram hour. A part of the radium is applied in the uterine canal, and the rest is divided into two halves and placed in two colpostats. Colpostats are cylindrical applicators made of cork or sorbo rubber applied high up in the vaginal vault. And colpostats separated laterally by a spring and modified by the Manchester group known as the Manchester system. And Stockholm technique is devised by Fossel and Heyman. Large amount of radium is used, enabling shorter treatment time. Applicators are stainless steel of length 53 to 70 mm and 7 mm dia. Larger diameters of less than or equal to 13 mm is used to avoid excessive dose to the uterine wall. These are the permanently loaded tandem has 53 to 88 milligram of radium and designed to provide 75 R per hour dose rate at 2 centimeter from the center of the applicator. And ovoids vary in shape and size and contain 60 to 80 milligram radium. Treatment time is generally about 27 hours in 2 sittings, 3 weeks apart. And the Manchester system main feature is selection of reference point in the pelvic cavity for those specifications and those specification in terms of R. Criteria is anatomically comparable from patient to patient, not highly sensitive to small and clinically insignificant alterations in applicator positions, allow for correlation of dosage and clinical effects. The reference points based on these criteria were suggested by Manchester system. And source loading is 20 to 35 milligram of radium in intrauterine applicators and 15 to 25 milligram of radium in vaginal ovoids. We can see that it is 1/3 of the activity of the radium used. And the point A is defined as the anatomical position chosen in the paracervical tissues 2 centimeter lateral to the central canal of the uterus and 2 centimeter above the vaginal wall. Anatomically, point A lies in the region where the uterine artery crosses the ureter. In fact, point A lies on the apex of a triangle formed by the uterine canal, uterine artery, and ureter. And this is called the paracervical triangle. And significance of point A, this region is important in respect to tissue tolerance and is often the site of early infiltration and hence not to be underdosaged. Paracervical triangle, where initial lesion of radiation necrosis occurs, and area in the medial edge of broad ligament where the uterine vessel crosses over the ureter. And point B is 3 centimeter lateral to point A. In an average patient, point B lies close to or on the pelvic wall. The significance of point B is this gives an indication of the fall of dose in the pelvic region. The dose rate at point B is very useful for supplementary external beam irradiation. Rate of dose fall off laterally and important for calculating total dose combined with EBRT. Proximity to important obturator lymph nodes. Same level as point A but 5 centimeter from the midline. Doses of approximately 20 to 25% of the dose at point A. This ensures the dose fall off laterally. Here we can see this is the point A, 2 centimeter above and 2 centimeter lateral, and another 3 centimeter lateral is the point B. And the loading pattern, in order that point A receives same dose rate, no matter which ovoid combination is used, it is necessary to have different radium loadings for each applicator size. The dose rate to point A is 57.5 R per hour and not more than 1/3 dose to point A must be delivered from the vaginal radium. So there are different types of central tandem as well as the vaginal ovoids of different size in sizes of large, medium and small. The central tandem has large has 6 centimeter length, medium has 4 and 2 centimeter, small, and the tubes and the radium milligrams of radium for each of the tubes and the units for the ovoids and the loading pattern for each of the tubes. And similarly, the same is done for the ovoids also, the different milligram of radium and the amount, the units in each of the tubes and the loading pattern for each of the tubes. And ICRU 38 compare different treatment techniques and evaluate their respective merits and compare the present concepts with historical series and derive new clinical and radiobiological data. And dosimetric information for reporting complete description of the technique, time dose pattern, treatment prescription, total reference air karma, dose description, prescription points or on the surface of the applicator or the source, and reference dose in central plane or mean central or peripheral dose, and volumes treated or point A or a reference volume, and dose to organs at risk, majorly for bladder and rectum. And reference volume, dimensions of the volume included in the corresponding isodose. The recommended dose is 60 gray, defined as the volume encompassed by reference isodose surface, which is 60 gray of absorbed dose for low dose rate therapy. When the brachytherapy is combined with external beam therapy, then reference isodose will be 60 gray minus the dose delivered by external beam. For MDR and HDR, the therapist has to decide the dose level which he or she believes to be equivalent to 60 gray of LDR. Volume encompassed by reference isodose surface, the absorbed dose of 60 gray is accepted as the reference dose level for low dose rate therapy. And description of reference volume in terms of height, width, and thickness is also there. The height represented by DH is the maximum dimension along the intrauterine source measured in the oblique frontal plane containing the uterine source, and width is the maximum dimension perpendicular to the intrauterine source measured in the same oblique frontal plane, and thickness is the maximum dimension perpendicular to the intrauterine source measured in the oblique sagittal plane. So here we can see along the intrauterine source, the maximum dimension is DH or height in the frontal plane, and for the DW or the width perpendicular to the axis of the intrauterine source, DW is the maximum dimension. And in the sagittal plane along the intrauterine source, the maximum distance is the thickness. And reference points for organs at risk for the bladder point, rectal point, lymphatic trapezoid of Fletcher, low PA, low common iliac lymph node and mid external iliac lymph nodes, and pelvic wall points, distal part of parametrium and obturator lymph nodes. The bladder and the dose to bladder and rectum may be calculated by visualizing the organs in radiograph with respect to the position of active sources. To visualize bladder in radiograph, a radio opaque dye is injected into it at the center of the balloon in AP radiograph, and on the lateral radiograph, the bladder point is taken on a line drawn anterior-posteriorly through the center of the balloon at the posterior surface. On the frontal radiograph at the midpoint of the ovoid sources, and rectal point is taken on a line drawn from the middle of the ovoid sources 0.5 centimeter below posterior vaginal wall at the level of lower end of the uterine sources. And to visualize vaginal wall, radio opaque gauze packing is used in the vagina. Alternatively, rectal dose may be measured. So here is a pictorial representation of where the bladder point is and the rectal point is. Bladder point is taken on the posterior surface of the bladder, and the rectal point is taken on the anterior surface 0.5 centimeter posterior to the vaginal posterior vaginal wall, and with respect to the intravaginal sources. And reference points related to bony structures can lead us to identify the para-aortic nodes, common iliac nodes, and external nodes. In a lateral radiograph, a line is drawn from the junction of S1, S2 to the top of the symphysis. So in a lateral radiograph, a line is drawn from the S1, S2 junction from here to the top of the symphysis. From the middle of this line, a line is drawn perpendicular to the anterior most aspect of the L4 vertebrae. And 2 centimeter lateral to this point are the left and right para-aortic nodes, and 6 centimeter lateral to the lower one is the left external iliac and right external iliac nodes. And if we join the trapezoid, the midpoint of these two lines will give us an idea about the right common iliac and left common iliac nodes. And the treated volume bear the shape of a pear or banana. Receive the dose appropriate to achieve the purpose of the treatment. Example, tumor eradication or palliation within the limits of acceptable complications. And irradiated volume is the volume surrounding the treated volume, encompassed by a lower isodose to be specified. Example, 90 to 50% of the dose defining the target treated volume. Reporting irradiated volumes may be useful for interpretation of side effects outside. And ophthalmic plaque therapy is used when we require to treat eye cancers using brachytherapy. The common tumors treated are choroidal melanoma in adults or retinoblastoma in children. And plaques as sources are in the plaques, the sources are permanently loaded, and these are sealed sources, and it is inserted temporarily. And the commonly used radioisotopes used for ophthalmic plaque therapy are strontium iridium source and rubidium ruthenium source or phosphorus 32 source or iodine 125 source. And the details, the half-life, maximum beta energy, gamma energy, and the process in which the sources are created are tabulated in the table. And endovascular or intravascular brachytherapy is for the management of obstruction or blockage in the blood carrying arteries. The modes of treatment are bypass surgery or PTCA with a stent. Drawbacks of bypass surgery is patient trauma and more failure cases. And coronary arteries are those arteries related with the heart, and peripheral arteries are other than the heart. And endovascular and intravascular brachytherapy prevent the restenosis, and restenosis is the reblockage of the arteries. And the reasons for blockage can be injury due to PTCA procedure or thrombosis, and the stents used are normal or radioactive stents. Sources used are both gamma emitters and beta emitters. Gamma emitting sources used are iridium 192, iodine 125, palladium 103, and beta emitters are strontium yttrium 90, P32, tungsten rhenium 188. So these radioactive sources, radioisotopes, and their emission and half-life, energy is tabulated in the table here. And radiation protection, we have to ensure no source is lost, and in the computerized remote afterloading technique, the possibility of source loss is much lesser, and we can apply time distance shielding for achieving the as low as reasonably achievable doses for protection. And the practice needs to be optimized such that the patient and personnel involved does not get any undue radiation hazard, and there is no chance of spillage as we are not using any liquid sources. And there are proper guidelines in case of emergency, and these guidelines shall be adhered strictly to ensure proper radiation protection in the facility. Thank you for your patient hearing.
Thank you, Dr. Marry. It was a really good